Dear colleagues, friends, companions, people in front of the screen, welcome to this PCR webinar dedicated to the treatment of calcified lesions. This has been made possible with the collaboration between Europa, PCR, and an unrestricted grant from Boston Scientific. Today, I have the pleasure of working together with two very well-known friends of mine, Professor Emanuele Barbato, who works at the Onze Lieve Brown Ziekenhuis in Aalst, Belgium, and Dr. Margaret McEntegard from the Golden Jubilee Hospital in Glasgow, Scotland. They are very well-known experts in the treatment of complex and calcified coronary arteries. This is what we want to share with you today. The reason you are supposed to be there is explained in the next slide when you see our aims. It is to involve you in the planning and performing of a complex PCI of a calcified lesion in a bifurcation, which is a very delicate bifurcation. It's the left main trunk with the Medina 111 presentation. We want to get you around the thoughts and the discussion on why, first of all, why we treat this patient and how. And then share with you the step-by-step technique to do the right thing at the right time with the right materials. And this will be with the use of rotational atherectomy, a dedicated device for calcium, under the assistance of intravascular imaging. So these are my colleagues today. I give them 1 minute to say hello. Emanuele.
Yes, thank you very much, Flavio, for the kind introduction and the kind words. I'm looking forward to share this PCR webinar with all of you, and I hand over to Margaret.
Yeah, thanks, Flavio. This is going to be a great webinar focused around a fantastic case, but done by yourself. I think everybody's going to really enjoy it.
Okay, so Margaret, tell us about the case.
So the case we've got today is an 85-year-old man who is otherwise very fit and well. He had a very active, healthy lifestyle. He was previously a paratrooper, and he's got normal renal function and normal LV ejection fraction. So he presented having had a 2-year history of progressively worsening angina, and that's got particularly bad over the preceding 3 months, despite optimization of his medical therapy, and it was CCS class 3 at the time of his consultation with yourself, Flavio. So here's the baseline angiogram that you performed. So what you can see here is a caudal view of the left system. And what's very striking is the severe calcific disease involving the left main circumflex and the ostium D. And you can see there's protrusive calcium into that left main carina. The other thing that's quite clear is there's a clear shelf of calcium into the ostium and the proximal LED. You can see that on one side of the vessel. And there's a further lesion down at the bifurcation at the circumflex and OM, which also appears to have some calcium. If we look at a second caudal view from the LAO, again, we can see very clearly this protrusive calcium angiographically into the distal left main carina, involving the ostium of the circumflex and also extending into the proximal LED. And again, you see that lesion at the bifurcation of the circumflex and OM. In the cranial view, what we can see is there's what looks like quite a nice angiographic landing zone in the LED before the diagonal bifurcation. There's some disease in that diagonal, which is probably moderate, and a little bit of modest disease further down the LED, but there's quite a nice platform there for us to land our stent in.
Okay, thank you, Margaret. So what comes first in this case is whether we have to treat a patient with stable angina at the age of 85 with normal LV function and normal kidney function. The point is that his angina has been worsening in the last month and now really compromised his style of living, which is very good, despite his age. So we have to consider not only the prognosis in this case, but also the quality of life beyond the optimal medical therapy. So, Emanuele, you are a professore, so we ask you, what about the indications provided by our European guidelines?
Thank you very much, Flavio. But, well, perhaps before going through these couple of slides on the guidelines that are not always exciting to listen, it would be much better to hear from our colleagues. I don't know whether they are with us, and if they are with us, please show that you are interested in what we are telling by telling us whether you would embark in this revascularization, whether you would do PCI in this case, whether you would send the patient to the surgeons, or whether you would do nothing, just medical therapy. I mean, the three options are open, as Flavio was alluding to. But let's see what the guidelines are saying in this specific case. Of course, we have a post-hoc knowledge of the coronary anatomy in this patient. So we are already one step ahead. Nevertheless, we can apply the 2018 ESCTS guideline on myocardial revascularization. And you can see that for left main disease with the stenosis more than 50%, which is our case, there is a class of recommendation 1 with a level of evidence A. Even if we do not have from the slides we have seen, but I will be very curious to hear Flavio thereafter, we do not have notion of any non-invasive diagnostic workup. We know that this patient has normal resting left ventricular function, which is already giving us a piece of information. We can anticipate that this patient has a large area of myocardial ischemia, considering that a left main is involved in this coronary atherosclerotic process. For symptoms, for sure, we know that this patient is symptomatic, has typical stress angina. And what we also don't know, and this will be again a question to the colleagues from Verona, is whether this patient did an attempt with a maximization of the medical therapy before considering coronary angiograms. But, you know, these are all ex post reasoning, useful to fire up the discussion. For sure, and I think this is of interest to all of us, this will not be a patient eligible for the ischemia trial. Why? Simply because this patient would have been excluded would the CCTA be performed. Because you remember that to be included in the ischemia trial, these patients should have been performed coronary CT, and in the presence of a tight left main stenosis, as it was in our case, these patients would have been excluded. So no eligible for ischemia trial. Nevertheless, I invite you to consider the fact that in an elderly patient, 80 plus years old, CCTA is not the first test we would consider in our daily practice. Why? Because we know the diagnostic accuracy of CCTA in elderly patients is lower and lowered by the expected amount of calcium present in these coronary arteries. So if this patient would have been managed outside the ischemia trial, no CCTA performed, first of all, most likely we would have done some non-invasive functional testing, echo stress or whatever. And what the trial is telling us is just give it a try with medical therapy. Go on. Can you imagine? This patient would have been denied a coronary angiograms, would have been denied a further anatomic stratification. Back to you, Flavio.
Thank you, Emma. Really 100% agree with you. I met the patient for the first time when he came saying, you know, I've never been in a hospital before, and I have been feeling chest pain for more than 3 years and taking more and more pills, because he had his personal cardiologist and he was upgrading and optimizing medical therapy until he decided to send his patient to my attention, because the angina was really making a very bad lifestyle for him. And at that point, after having talked for 5 minutes with him, I decided that there was no need for a stress test. It was typical angina. He had normal LV function, normal hemoglobin, normal kidney function, such a wonderful fit man. And he went directly to the cath lab and he did the diagnostic angiogram. This is a true story. I'd like to ask the next point, because we say, okay, we will treat this patient because he deserves treatment, both for his quality of life and because despite his 85 years old, his life expectancy, it's reasonable. But how to treat him? I mean, Margaret, can you analyze what we can understand from angio and from clinical scores, whether he's a good candidate for surgery or better for PCI?
Thanks, Flavio. So if we look at his surgical scores, he's a EURA score of 15 and an STS score of 8.1, so kind of intermediate towards high risk in the surgical population. If we look at his anatomical score, his syntax 1 score is 21, which puts him in the actually just into the lowest tertile of the anatomical complexity. If we then go on and look at his syntax 2, it's 45.3 for cabbage, giving him a 4-year estimated mortality of nearly 23%, and 31 for PCI with an estimated 4-year mortality of 7.5%. So if we go on and you again consider the guidelines, and we think specifically about this patient, so what we're dealing with here is left main disease with a syntax score of 0 to 22. So if we look at his two options here, bypass or PCI, the guidelines suggest that both have a 1A indication. If we look at what data we have from the randomized trials, if we go back and look at the syntax trial, now 10-year all-cause mortality outcomes, in a trial where we use first-generation drug-eluting stent versus bypass surgery, what we see is in a patient like this at 10 years, there's no mortality benefit for bypass surgery over PCI. Now, this is an 85-year-old man, so in the general population, that might not be particularly relevant. But as we've alluded to, he's a very fit 85-year-old man who is not, and going back to the discussion we just had a few minutes ago, not all 85-year-old patients are the same. You'll come across a 65-year-old patient who is more complex and higher risk than this 85-year-old man. So I think it's important to interpret the evidence and the guidelines in the context of the patient in front of you in the clinic.
Yeah, Flavio and Margaret, if you allow me, we start having some interaction on the chat, and I'd like to share with you the two comments that I selected. The first one is just following the very last consideration from Margaret concerning the, let's say, application of the knowledge of the guidelines to the individual patient. And the question that comes from the colleague is whether this patient has been discussed within your heart team in Verona. I think that's the best forum to apply evidences to the case-by-case scenario. Flavio, to you.
This is an absolutely important point. We never perform a left main elective procedure without a round with the patient, his family, and our surgeons. This is not an emergency. The guy went to the cath lab walking on his feet, and he could decide to stop after the angiogram and improve further therapy after you explained the risk and benefits of the therapy. He, of course, had an interview with the surgeon, but also the surgeon agreed that if there is a possibility of treating non-invasively, minimally invasively, he would be happy not to open the chest at 85 years old. But any elective case, treating the left main, and especially when we deal with calcium and bifurcation, deserves very cautious discussion and very thorough, informed consent of the patient. Indeed, you will see that the procedure was performed days later and not immediately on the same diagnostic day.
Good points, Flavio. Let me just further extend, because part of the same question from our colleagues, Lars Jorgensen, I guess the pronunciation is correct. Thank you, Lars, for this question. And let me extend this question to Margaret. Would you routinely discuss these patients at your heart team? And part of the question is whether patients take part to the discussion at the heart team.
So yes, we would, just like Flavio said, the patient's entirely stable. We would take him off the table and we would discuss him at the heart team, we would plan to keep him in to revascularize him because we've found severe left main bifurcation disease, and we would be concerned about any delay in dealing with that. In terms of involving the patients, that's something I feel really strongly about. I think that a patient like this will be able to engage with the evidence. I'll give the patients the syntax 2 data. I'll sometimes even give patients printouts of some of the clinical trials if I feel that they're up to discussion and interpretation of the evidence, and have a very active, informed discussion with a patient like this and allow them to participate in the decision making and ultimately make the choice of what they feel is the best option for themselves. Obviously, we know we come across patients who are not as capable of that type of interaction, but I think we owe it to the patients to try and allow them to make an informed decision. I think in this patient, the most important thing is his age, because he's obviously otherwise very fit. And I think in a man like this, who's 85 years old, who has a complex cornea anatomy, but something which is eminently fixable and experienced hands with good technology, that I think PCI for him was a great option.
Flavia, I have another question, but you are the master of ceremony. Tell me whether you want to take it now or later.
No, I mean, I think we can continue with the planning of what we have in mind. It's an important issue because we say, would you discuss this with your surgeons? We have to realize that probably 1 out of 8 or 9 hospitals with interventional facilities have a surgeon on site. So it might have, this patient might have an angiogram in a hospital where the surgeons are not available. So what you have to think in this case is, let's suppose that the worst is happening and you have a complication and your left vein is occluded. And it's an 85 years, very fragile man. Probably you don't ask the surgeon to open the chest under an emergency circumstances. But in this case, there is no doubt that my surgeons would open the chest to this patient and put at least a vein on the LAD, and probably he would survive. So the risk-benefit balance is always very important when you afford PCI that we will discuss, because one important thing is that when we measure scores, angiographic and clinical, we will see that it's not so clear whether it is a high-risk patient or low-risk patient, if it is simple or a complex procedure.
Very quick point, Flavia, because I think it belongs to this part of the discussion. First of all, colleagues are okay with doing PCI, and there is one interesting argument made by Ramakandra, who's saying, who's speaking about 4-year mortality with PCI versus CABG. I think that is an important issue. A factor that we should always include into the equation is the life expectations of our patients. What are we achieving with our procedure? Prolongation of life, quality of life. We have to consider that there is a timing to which PCI is superior in terms of results. Up to 2-3 years, performing PCI is better as performing CABG. While we have to wait, as you nicely showed, Margaret, 4, 5, 6 years before starting observing some advantage from CABG. So what do we want to afford to our patient? And I think that is extremely important to explain and to include patients into this discussion. So I hope we addressed all the points thus far, and I give the word back to you, Flavio.
Okay, thank you, Emanuele. So let's start thinking with the patient on the table. This is the angiogram. We reviewed before. Margaret described it very nicely. It's a Medina 111. That means that all the parts of the bifurcation are involved in the tight stenosis. Angiographically, it's evident that there is a lot of calcium, but this is not very reliable information. These are quite short lesions in large vessels. That makes the procedure easier, or let's say the operator more comfortable. There is no diffuse disease. The landing zones are okay. And there is a second bifurcation on the oblique marginal and the distal circle. So the first thing, and we are sharing with you this way we have of working, is adding the intravascular analysis on these patients. So put your wire on the LAD and try to cross with the IVUS probe, or if you want to make it even safer, put the two wires, one on the LAD and one on the CERC, the wire you like, you don't need special wires for that, and make this IVUS interrogation. You see the probe, surprisingly, I would say, crossed the left main and went to the LAD, and also made the bend to the CERC and went to the CERC. So we can analyze together these images. On the bottom left, you will see the pullback, but we have selected some spots which are significant for the decision-making process. At the left main, the amount of calcium is more than 180 degrees of the circumference. And it's a very deep calcium. You see that the dark part, this dark cone, goes up to the adventitia. That means that the calcification is really very deep, involving all the vessel wall. And this extends to the proximal part of the LAD. When we move to the beyond the LAD lesion, we confirm that there is a good landing zone. When we analyze the circumflex, the bifurcation of the left main looks even worse. And we see in the central image a spot which shows a big nodule of calcium. And this could be a big problem. We will see why. The ostium of the CERC has more than 270 degrees of calcium, again, very deep. And then we arrive to the bifurcation of the first oblique marginal, which is clean. So we can plan the secondary bifurcation as a, let's say, provisional strategy. The distal part of the CERC is calcified. You see in the bottom image, which has 180 dark cone, but the lumen of the vessel is widely painted. So these IVUS analysis tell us a lot of things about how to manage with this case. We have two different scoring systems, one based on OCT and one based on IVUS. I personally prefer IVUS because you don't give contrast media, which is a poison, okay? Especially in an 85-year-old male. The OCT base says that when you have more than 4 points in this score, that you reach having an angulation of calcification more than half of the circumference, 180, when the thickness of the calcium is deeper than 0.5, and this is easily seen with OCT, not so easy to see with IVUS, and the length of the calcium is more than 5 millimeters, you have high risk of underexpansion of the stent, and this means, of course, risk of thrombosis and restenosis. In this case, it is appropriate to use dedicated device to treat calcium, which are rotational atherectomy, orbital atherectomy, or lithotripsy. If you prefer to do IVUS, which is what we did, it's more or less the same. You see how extended is the calcium. We know it's more than 270 degrees in our case. It's very deep, and you have also nodules. So this is, again, a high score that recommends, this has been done from colleagues from New York, from CRF, the use of a dedicated device. So, Emanuele, now we have angiographic, clinical, and IVUS information. Which should be your driving thought in our decision-making plan?
Well, let me integrate my answer by using some of the questions coming from the colleagues. First of all, procedural setting. And one of the colleagues asked whether femoral approach is a standard approach in this case. So I tell you what I would do. I would always give it a try to do a radial approach if possible. But I give you the word and comment on this specific point.
I absolutely agree. Radial should be the default. In this case, the diagnostic was done from radial and the arteries were small. We decided to use a 7 French guiding because it was a default 2-stent strategies. And this is why we went from femoral. Plus the fact that the case was done 6 years ago. Okay,
well said. Do you share the same approach on this, Margaret?
Yeah, exactly the same as both of you. I would do it 7 French radially, but if I couldn't do it 7 French radial, I would do it from the femoral.
Excellent. So we are well aligned on that. Let's move one step forward, and we also try to address one of the points raised by the colleagues. How would you guide your procedural strategy just based on angiogram? But actually, you already addressed this question. This is really a case where we should try to do intravascular imaging. And you nicely showed that with the IVUS, you could even cross these tight stenosis. One of the colleagues was concerned about, it was actually Irene, who said, didn't you decide to predilate the tight lesion on left main before doing IVUS? And I agree with you, you give it a try. You give it a try. If the IVUS goes, well, then it's already an interesting feedback for you. If IVUS doesn't go, then it might be even tough for a balloon to cross. And here I want to open a discussion because we already know that this is a heavily calcified lesion. Would you and Margaret take the risk of doing a little predilatation, you know, even with small balloons? We sometimes do that. We do a little balloon just to probe. But sometimes it happens that you have very nice dissections and you, in a way, would prejudicate the possibility to do rotablator. So I'm curious to hear your practice. So if the IVUS doesn't cross, would you switch immediately to rotablator, or would you still attempt little balloon dilatation and IVUS? Because this opens the door also to the next question that I want to do to both of you. Who starts first? Margaret, perhaps.
So in this particular case, if IVUS wouldn't cross, I would go straight to rotablation. And the reason is that the angiographic appearance to me is very convincing for protrusive nodular calcium. So I think that the angiographic, the IVUS is very consistent with what I anticipated on the baseline angiogram, just from experience, I suppose, over time. So I would have gone straight to rotablation and then IVUS after the rotablation to assess the morphology. Flavio, what would you have done?
Exactly the same thing. In this case, I'd like to have the procedure under control. And I know that doing a rota cross with a small bar, the procedure will be always under control. And then I do the IVUS analysis. Putting a balloon may be okay, but as Emanuele said, you can have surprises.
Okay, I don't want to open now the discussion to other ablative techniques that might require very often predilatation, and I'm alluding to IVL, of course. But Margaret made nicely the case from the angiographic appearance. It was clear that this was a case for rotablator. You know, it's something difficult to explain sometimes to the community that from the angio, after you reach a certain experience, you can already select the right device and the right approach for that individual patient. So I agree with you, Flavio, going back to the decisional three, I would go through radial approach, angio, good angiograms like you did, IVUS guidance. It's a complex technique, so perhaps I would use here a 7 French guiding catheter. And then there are additional points that were also raised by the colleague, need for mechanical cardiac support. It's open for discussion, but I would not do it, and we will hear the other colleagues simply because there is a normal resting left ventricular function. I understand from Flavio that the hemodynamics of the patient is also well preserved. So in my opinion and in my experience, but also based on the evidences that we have, I don't think there is really the need for myocardial support. And I want to hear my colleagues on these last 2 points.
So I agree with you. Yeah, I agree with you. So he has preserved LV function. And I think in this particular situation, you could argue that the vascular access risk is higher than the risk of proceeding without mechanical circulatory support. So I would do it without it as well.
That's the point. Exactly same angiography with 30% ejection fraction and a systolic blood pressure reaching 100, I'd put the patient on a system. Totally normal hypertrophic LV function with 140 millimeters of mercury of systolic blood pressure and 75 beats per minute, you can do it safely and have it on standby, of course, in your lab, but not put it in as a preventive measure.
Okay, I have other comments and questions, Flavio, that we can address while going through the case. So if we go back to the slide, perhaps.
Okay. So we prefer to do PCI, and we explain this very clearly. As I said before, it's a little bit tricky if you consider the risk, clinical, and the procedural, what is complex, what is not complex. I just summarize saying this is a complex bifurcation with a lot of calcium, and we will put 2 stents. So this makes of it a complex procedure despite the low syntax score. I think you agree about that. It's a clinically low risk patient because he's healthy, fit, no comorbidity, but he's 85. So he's beyond the life expectancy. And so obviously he's fragile. Why using rotablation? This is a very special point. We said we need, according to the IVUS score that we have well analyzed and the OCT score, we need dedicated devices. These are high pressure balloons, orbital atherectomy, rotational, and IVL. Margaret, why did we decide to use rotational atherectomy in this case? Apart from being a sponsored session by Boston, of course.
So for several reasons, Flavio. So firstly, there's protrusive calcium into the lumen, and that needs to be debulked. You're just trying to push a nodule out of the way is exposing the patient to very high risk of vessel rupture. So we need to debulk that calcium that's protruding into the lumen. And the only device currently widely in use, and certainly currently in use in our centre for this procedure, is rotational atherectomy. In addition to that, a lot of the other calcium is also eccentric. So some of the other devices that you might use, for instance, IVL, have doubtful impact in that setting without concentric calcium in a lot of the areas around the bifurcation. We're also dealing with a very large caliber vessel in the left main. So we have the ability, obviously, to upsize our device to ensure we get adequate debulking. And I think most importantly is around the left main bifurcation, the most important thing is that we achieve good minimal stent areas at the end of the case. And to do that, we need to debulk the lumen. So for me, in this case, it has to be rotational atherectomy. Yeah. In addition, this is a good point. So we have to also remember that this is a very proven, efficacious and safe approach to dealing with this type of disease. We've had rotablation available now for 30 years, and apparently is now being used in over 1 million patients worldwide. And this obviously means a lot in a very evidence-based specialty like interventional cardiology.
Yeah, this is an important point. Sometimes the device is perceived as being demanding and sometimes a little bit risky, but it's exactly the contrary. I mean, once you are confident with this technology, it's the most tested and proved technology ever used in calcified lesions. And this is true. Millions of patients treated, decades of experience. And so it's a very well-validated technique. Of course, you need to learn how to use it. And this is why we are here. Emanuele, would you mind explaining now step by step to our colleagues what we're going to do so they can take a piece of paper and a pencil and write 1, 2, 3, 4, plan A?
Sure, thank you very much. And actually, by doing that, I will also address some of the points that were raised in the meantime in the chat box. So for sure, we need to do sequential rotational atherectomy in this bifurcation, in this left main bifurcation. So this means sequential wiring. We would first wire the LAD with the rota wire. And in that case, it is safe to start small and then increase and enlarge the bar size. That's why I agree with the proposed strategy with 1.5, 175 millimeter bars. Once this is done, the rota wire can be safely pulled back and positioned into the circumflex. With large experience, you would be confident in doing that. No worries, if there is one technique that would not prevent you from rewiring the other vessels or getting back to the LAD, this is rotational atherectomy. Then you would do also to the circumflex rotational atherectomy, again upsizing from 1.5, 175. In the case, I guess Flavio went straight away to 175. I would be more conservative to start with. But then once rotational atherectomy is performed, the procedure is not yet over. Keep that in mind. You still have to continue with your plaque modification. That is the reason why very often we like to use non-compliant balloons, but there might be deviation to this protocol. You might want to use, cutting or scoring balloons or other little bit more expensive plaque modification tools and techniques, and we can discuss about this. Then I think most of us would agree that this is a case for a two-stenting strategy. It is a true Medina 111. Then we can discuss about the specific stenting technique, but it's very likely that we will end up with two stents implanted in this case. And finally, although it is very elusive to think that we would have a perfect circumferential result of our stent, we should do our best to optimize the stent implantation with non-compliant balloons, at least to improve the stent wall position. Forget that we would reach nice circular stent results. Final IVUS assessment, and then there will be some consideration on the medical therapy at the long term. Back to you, Flavio.
Thank you, Emanuele. The plan is clear. I mean, everything is good when you can stick to the plan, and this is what we are going to try to do. So let's start doing the case, and the first thing is putting the wires. Rotablation needs dedicated wires. These are called rota wires. There are two types of rota wires. One is a floppy one, which is a little bit easier to manipulate and gives less support. And the other one is the extra support. It's a little bit more rigid and gives more support. In this case, I think any would fit, and I decided to use the regular floppy wire. If you're not used in moving these wires, you can put your regular wire distal on the vessel, put a microcatheter, retrieve the workhorse, and put the rota wire. And sometimes you will spare a lot of time. But of course, the more you use it, the more you get confident. And sometimes you spare time going straight forward with your rota wire, which is 3 meters long, because the system is an over-the-wire system. Once the wire is on the LAD, you retrieve the wire you have put on the CERT to do the IVUS analysis. Remember, never rotate on 2 wires. Some people do it, but you'd rather not. This is our message. Once we have put the wire, we have to rotate. And we have a very expert person in the group. Margaret, how would you deal with the bar in this bifurcation?
Okay, so the first thing you're going to do, what you see here in the left is the new RotaPro console, which is very user-friendly. And what you can see is that it's set to start at 160 RPMs. So you're going to set up your system and test the bar outside the body like you will always do. And then you're going to advance the bar over the rotor wire. And what you see on the right-hand side there is Flavio advancing the 1.5 millimeter bar into the left main. And he's using this very classical pecking motion. This is important because what you want to do is you want to make sure that as you cross the disease, you're adequately debulking it so that you're not going to get the burr stuck on the other side of the lesion without having modified it enough with your first cross. So it does several crosses with that, and then a few polishing runs just to make sure that you've adequately debulked that and that segment in the proximal LAD. And you see that here on the angiogram on the right-hand side. So this pecking motion. Now the burr size, the burr comes in a variety of sizes. What you see here are the most commonly used 4 sizes: 1.25, 1.5, 1.75, and 2.0. So after debulking with the 1.5, because we're dealing with the left main and we know the lumen's large and we know we've got that big protrusive calcium, the upsize to 1.75 burr. And you now see, again, being careful to do this pecking motion, especially as the burrs get larger and larger, to ensure you're debulking on the way forward so you don't get the burr stuck or stalled on the way back. And the new console is lovely because what it does is that as the burr slows, it shows you initially a yellow triangle and then a red triangle to alarm you that you're getting decelerations and you're likely to possibly stall the burr if you continue. So once it debulked the LED, they've delivered a second rotowire into the circumflex, retrieved the rotowire out of the LED. So as Flavio said, you always rotate on 1 wire, not 2 wires. And then the circumflex, having debulked most of the calcium in the left main, Flavio goes straight to a 1.75 burr and then debulks into the circumflex. So he has the confidence to do this because he's already used a 1.5 and a 1.75 across the bifurcation into the LED. And then after several rotations with the 1.75, you see eventually that crosses nicely down beyond the bifurcation in the circumflex. And this is the angiogram after the debulking of both limbs of the left main.
So, Margaret, this is an important point. I mean, sometimes you get a little bit disappointed when you see the angiogram after rotation, because it seems not to be a big difference in between. It's not a balloon that you open and you eliminate the stenosis. You have to get used to that, and you have to trust that the device has done his job. And Emanuele, after you have done the rotational atherectomy, which are the key points you have to concentrate to make sure that you still keep your procedure and your patient under control?
Yes, Flavio, these are nicely listed in this slide. Well, the first thing is whether we damage the coronary flow of the patients. What I used to do at the end of each rotational run is just a little flush with diluted contrast. That gives me the idea whether I jeopardize the antegrade flow of the vessel. Of course, if something wrong happens, the patient will immediately inform you by complaining of chest pain or by showing ECG changes. And sometimes, if you happen to see no reflow, true no reflow, you have even a drop in systemic blood pressure and bradycardia. We happen to see this sometimes. But please don't be misled in this specific case. You noticed perhaps at a certain point in time, the flow in the LAD was a bit sluggish. That is not just after burying. It was there from the onset, from the beginning. And this is an information you have to keep in mind. So that is why it is extremely important to carefully read the images before you go on with your procedure, because the knowledge of the slow flow at the beginning of the procedure would prevent you to do unnecessary actions at this point in time in your procedure. Then I would evaluate for dissections, if I can have back that slide with the list. I would evaluate for dissection angiographically, but what I like to do, since I have the IVUS probe open and if I'm not in a rush, I would just do a quick pull back with IVUS to make sure that I truly disconnected the ring of calcium that prevented me to advance with the IVUS probe before, or to expand the balloon before. I would make sure of that, and I would use the opportunity to size the balloon and the stents. And finally, I would decide the stenting strategy. But for sure, there is an intermediate step that is still missing: careful balloon dilatation and verification of the efficacious plaque modification.
I think at this point of the procedure, we are at a crossroad. You will see what we did, and you will see that there is no IVUS analysis after rotation, which I would recommend to do when you start using the technology, because you learn about what you see. And so how does it work? We said before, after rotational atherectomy, the stenosis look pretty the same. I mean, you don't see an enlargement of the MLD. It's a little bit disappointing. But if you get with the IVUS, you see the effect of the rotational. These pictures I have passed it in the bottom part of the slide are not relevant to this case. These are other pictures, but just to show you a 360-degree calcification on the left, how it looks after rotablation, where you see clearly 2 points of fracture. On the right side, you see 180 degrees with this dark shade cone here before rotablation, and then you clearly see the points where the plaque has been fractured. And this is where the balloon will open. So when you get used to see that, you don't need to do it in every case, because you want to do the procedure faster and simpler. But for those who start using the technology, this gives you a lot of information. As Emanuele said, it gives you an idea on the size of the balloon you will use, not to be too aggressive, not to do a useless dilatation with a too small balloon. And so in this case, we didn't do it. But when you start, you should do it. So what to do next? Shall we go with a stent, Margaret, or we still need to prepare this vessel a little bit better?
So what I tend to do is, as you've suggested, I usually will IVUS and look for fractures and look for debulking. And then what I almost always do is do one-to-one predilatation with a non-compliant balloon. So one-to-one vessel-sized non-compliant balloon, and look at the expansion of the balloon in a couple of orthogonal views to make sure there's no waste in the balloon. And then, depending again on the specific case, if I'm happy with that, if I've IVUS after the rota, I'll then go on and do my stenting. If I haven't IVUS after the rota and the patient is stable, I'll maybe at that point IVUS just to confirm that I'm happy. But I think one-to-one non-compliant balloon dilatation before stenting for me is a must. And as Manuel said earlier on, sometimes in this situation you might use a cutting balloon or a scoring balloon if you feel you need it.
Might it happen that after rotation, I mean, we did quite an aggressive rotation on the two vessels, upgrading from 1.5 to 1.7. Might it happen that you put a balloon and you still have a risk?
Yeah, I mean, I think there's always, when you're dealing with this type of disease, there's always a risk that by aggressively predilating at this point, that you could propagate any dissection that you've created with the rotablation. But in some sense, there's almost a need to modify the vessel adequately then to allow you to get a good stent outcome. So it's a balance between the risk of the modification versus the ultimate outcome of the stent. You have to make those decisions step by step during the case, constantly weighing up the risk-benefit balance of every decision you make in this type of situation.
Okay.
Can I quickly drop a question from Christian Dunn at this very regard? If after rotational atherectomy and further dilatation with non-compliant balloon, the lesion is not dilatable and you even end up with a dissection, what are you doing?
What would you do next?
Yes.
Yeah.
So you did rota, you did non-compliant balloon, you have a beautiful dissection, but you still have a waste in your balloon. What do we do next?
I would step up my modification. So you do not want to stent a lesion that you have not adequately modified. The worst thing you can do is put in an underexpanded stent for the patient's acute and long-term outcome. So at that point, I would reach for either a cutting balloon or IVL, depending on the morphology of the calcium, to make sure that I adequately modify that area. You become comfortable with experience with dissection. I think early on, dissection scares you, but I think as you get more experienced, you actually see dissection as a positive modification of the vessel in certain situations.
Good. Back to you, Flavio.
Yeah, it's a tricky question. I would make sure that your rotational atherectomy bar was not too much undersized. If the bar was too small, it might happen that you still have a risk with the balloon. And in this case, you can take a reasonable risk of upgrading with a bigger bar. If the bar was well sized, like in this case, and you still have a significant risk, then it's a problem. It's a problem because you will implant a stent which will be a little bit underexpanded, but you can still go more safely when you have the stent to go with high pressure. In the past, that was all you could do. Now we know that we have another weapon which is very effective, is that after you have done your best and your stent is still underexpanded, we shouldn't say it, but you can try with a little Tripsy balloon, which will effectively further expand your lesion. But this is not the case we're showing today. What we see now is the other result. Margaret, are you happy with this? Are you worried with this dissection? Would you go farther with balloons? Would you be more conservative? Are we ready to stent?
This is exactly one of these cases. So what we see here is quite extensive dissection into the LED and some further dissection in that circumflex down to the bifurcation with the OM. And we saw these balloons adequately expand. And we also may have seen fractures if we'd performed IVUS. So at this point, I'm not going to do any more pre-treatment. I'm going to go on and stent to secure the flow and the circulation here. One important point to make here is in this scenario where we know there's a lot of calcium and we've got extensive dissection, not to be too aggressive as we proceed towards the end of the case. So, I think as we implant the stents and we post-dilate, we should do that with some caution, because there is a risk, particularly in that junction of the left main and the LAD, that you could cause a problem and potentially rupture or perforate the vessel in that location if you're too aggressive.
Yeah. Emanuele, do you agree? I mean, we have been quite aggressive with the bar, and the 3.5 non-compliant balloon expanded very well. So I think we can go safely with the stent. How would you do this stenting?
I agree. We had beautiful dissection. I say beautiful dissection because this is the best angiographic sign that we can have, that we modified well our plaque in most of the cases, not always, of course. And as a matter of fact, we already alluded to the fact in the beginning that this would be a two-standing strategy. This decision is being reinforced by the fact that not only we have a secondary lesion in the circ to be treated, but also by this extended dissection into the LAD. So two stents need to be implanted. Now we can decide to go up front with two stents, apply some sort of DK crush technique. Personally, I wouldn't add additional complexity to a procedure that is already complex on itself. So if I can, I would try to avoid DK crush in this case, and I would go to provisional stenting, knowing that, I would start with provisional stenting technique, knowing that I would end up anyhow with a second stent. We know from the EBC left main trial that in 20-30% of the cases, two stenting strategy was applied down the road. So after having started with a provisional stenting strategy with beautiful result. And that is what I would do in this case, perhaps ending up with a top technique, with the top technique, yes. And actually, that was the technique you used, Flavio. You started with a stent crossing over from left main to the circ. Here we go. Then pull back the balloon, depot with a 515 non-compliant balloon. Then the first kissing balloon to the distal bifurcation, the one from the circ to the marginal branch. Then next, balloon dilatation to open up the stent struts towards the LAD, from left main towards the LAD, and a stent positioning, 426 from left main to the LAD. And I think we have a beautiful spider view where you nicely see how you carefully position the stents towards the LAD. The stent is dilated, there you go. And then further post-dilatation, kissing balloon. Let me go further with the slide. With a very nice, I wouldn't do like most of colleagues do, acceptable result. This is a beautiful result if we know from where we started from. And I think this is all for the stenting technique. Back to you, Flavio.
Thank you, Emma. Yes, we can ask whether it is good, very good. It's clear that the ostium of the LAD is a little bit underexpanded, but we have to remember where we start from, as you said, and then that this is an 85-year-old man. So the question is, shall we leave it as it is, or shall we have a look with the IVUS? The answer is very simple. We have the IVUS on the table, so we want to learn what we did, and we want to make sure that there is a good stent apposition and there is nothing wrong in the bifurcation. The question is, this we discussed already. We will not be more aggressive. We will not use IVL in this case, but have it in mind. If you have done the mistake of putting a very underexpanded stent in lesion, you can get more lumen using IVL, even immediately after stent. Of course, this is off-label, and the producer will tell you not to do that, but if you are in trouble, you will get better expansion. You can finish your procedure on this angiographic view, but of course, we want to see the IVUS. And this is what you get. This is the pull back from the LAD to the left main on the bottom right. You see the good stent apposition on the distal LAD. You see there is some asymmetry at the point of the bifurcation, but bifurcation is quite large. It's very nice. And the proximal part of the stent after kissing is very large. We have a very wide area of the left main, despite it's clear that there is still a mass of rock protruding in this bifurcation left main. As Margaret said, it's a very delicate point. And when we do the IVUS from the left, we confirm with really very big circumflex. It's nice to see that the origin of the oblique marginal is clean, as we predicted from the baseline IVUS, so we don't need to put 2 stents there. The distal part of the circ is clean. It's calcified, but it's clean. You see here the carina. You see the LAD and the circ, which is quite symmetric. You see it now live in this part with flow in the 2 vessels and a well-preserved area on the left main. So I think the case is done. And we can go to practical comments, and we have 5 minutes to add anything else or to address eventual questions from our colleagues.
So one comment, Flavio, just following up from what you said. When you deal with calcium like this around the left main bifurcation, you will always have eccentricity of your stent. Don't be tempted to try and get rid of the eccentricity of the stent. The most important thing is the stent area. And if your stent areas are good, do not try and improve the eccentricity. It's not going to improve the patient's long-term outcome or their risk of stent thrombosis or ISR. There's no evidence to show that eccentricity predicts that. So accept it if your stent areas are good.
Very well taken.
I have a number of questions from the colleague. If you agree, I put them on the screen next to mine. Well, I think you somewhat already answered to this one, Margaret. There appears to have a malapose and underexpanded stent in the proximal LAD. What is your position? Because you are an expert imaging users. After this very challenging procedure, you see malapose stent struts, underexpanded stent struts. What is your position on that?
Flavio, do you want to?
Well, you say in general or in this case? In this case, I didn't see under malapose struts. I mean, it is a little bit underexpanded where there was the mass of rock. But of course, it's a trade-off in between a perfect result and you have a coronary rupture and the patient dies in 2 minutes, or at 85 years old, this guy is now more than 90 years old and still doing very well. So you have to be, of course, always prudent when you treat these calcified patients.
When you see malapposition, sometimes in this type of calcific disease, often you'll see malapposition on either side of the nodule because it's impossible to get the metal to comply entirely around the nodule. Again, there's no evidence in this setting malapposition predicts adverse outcomes. But if you're wanting to pose a stent, one tactic is to take a semi-compliant balloon rather than a non-compliant balloon, so you reduce your risk of causing rupture, but you actually push the stent back in the points of where there's no resistance, where there's actually compliance in the vessel, into those bits of the vessel that you're unable to reach. But as Flavio said, I wouldn't chase, even if there was, and I didn't see any malapposition either, but even if there was, I wouldn't chase malapposition in that situation.
We have only 1 minute left. I would perhaps choose one question. We have many, by the way, that is really pertaining just tips and tricks. If IVUS doesn't cross, which would be the rotablator bar size you would choose first as a size? 125, 15, 175? Would you be influenced in the choice of the bar size from the fact that IVUS wouldn't cross, or from the vessel size? What would be your strategy?
I go first. This is a big vessel, so you can start with 1.5. If you go with a 125, you will do it quicker. You will pass for the first time quicker, but then you will need to upgrade. So you'd rather take more time. You take all the time you need, but in a left main, 125, unless it's a small left main, maybe not enough. And then when you put the balloon, as we said before, you may still have a risk.
So yeah, I always start with 1.5. I only ever use 125 if I've done several minutes with 1.5 and it's not going, or if I'm rotablating in the subintimal space in CTO. That's the only other time I'll use 1.25.
Okay, Flavio, I think back to you to wrap up. We are almost at the end.
Well, we are 25 seconds to the end, so we are perfectly on time. We have addressed most of the questions, but of course, 1 hour is it's enough to discuss. It's never enough to learn. And first of all, I want to thank Boston for providing us this opportunity, Europa and PCR, the two of you, giving us our time, your time, and an enthusiasm to share these difficult cases with the hope that this can be helpful to our colleagues and, of course, to our patients.
Thank you very much, and bye-bye.
Thanks, Flavio. Thank you. Bye.
Thank you. Goodbye.